All right. Good morning or afternoon, depending on where in the world you are. My name is Henrik Close, and the topic we'll be talking about today is the psychiatric assessment and interview of patients with intellectual disabilities. We'll have some time for questions at the end. Of course, if you have any concerns during the presentation, please type your questions in to the question box, and our friend Megan here will help with any issues you might have. Okay. So, couple things up front, disclosures. I am an employee of the Department of Defense. Otherwise, I don't have any disclosures or relationships to discuss. A little bit about me. I graduated from Wright State University Psychiatry residency in 2020. I'm currently working for Access Ohio in a telepsychiatry role there, where I see patients all across the state of Ohio with intellectual and developmental disabilities. I'm a faculty member of Wright State University Department of Psychiatry and the Uniformed Services University Department of Psychiatry and Family Medicine, and I am board certified in psychiatry. Technically, our board is in psychiatry and neurology, but I'm not gonna pretend to know that much about neurology. Anyway, disclaimer, this presentation is largely from a psychiatrist's perspective. I know that we have a lot of multidisciplinary folks in the audience today. This is going to be focused on establishing psychiatric diagnoses largely. That's the purpose of our psychiatric interview, but it's also going to be a helpful talk on just communication with folks with developmental and intellectual disabilities overall. It should be applicable to anybody from face-to-face care staff to physicians to behavioral support specialists, etc. So here's an outline of the conversation we're going to be going over today. First, we'll be discussing the diagnosis of intellectual disability, hereafter referred to as ID. We'll understand the ID interview per the Diagnostic Manual of Intellectual Disabilities, hereafter referred to as DMID. We'll talk about the ID interview principles and techniques, and then we'll discuss being flexible in the management and interview of patients with various forms of ID and some of the kind of stereotypic presentations of some of those disabilities. Okay, so first let's discuss the diagnosis of intellectual disability. All the photographs are going to be copywritten by the Special Olympics in this presentation. So the diagnosis of intellectual disability, let's talk about demographics. So 2 to 3% of the world population is estimated to have either cognitive deficits or intellectual disability. There are a myriad of biological and environmental causes. There's something like 1,000 biological causes of intellectual or developmental disabilities. Some are much more common than others. And there's also, of course, environmental causes. Lead poisoning is one example. Fetal alcohol syndrome is another one. Of this population that we're discussing, 30 to 40% will experience mental health issues, and 90 to 95% of those have experienced emotional, physical, or sexual abuse. That is to say, this is a highly traumatized population. It doesn't necessarily mean that 90% of the population has trauma disorders. It's just to say that a disproportionate percentage of folks with intellectual disabilities have experienced neglect. They've experienced inordinate hardship due to their inability to care for themselves as their own advocates sometimes, and their need of from support from other people, which unfortunately in some circumstances leads them to be mistreated. Folks with ID are also the most medicated segment of our psychiatric population, and you'll see this reflected in some of the topics we'll discuss later on. So how are folks with ID diagnosed with ID? The diagnostic manual that physicians and psychiatrists in that subpopulation use to diagnose folks with ID is the DSM-5 TR. It's the most developed form of the DSM-5 that recently released. Deficits in intellectual functioning are one of the core components required for a diagnosis of intellectual disability. And this is broken down as deficits in reasoning and deficits in abstraction. The other big category is deficits in adaptive functioning. So it used to be back in the DSM-4 that you pretty much got this diagnosis based on IQ, based on an intelligence quota score, and that was the sole component. Now we understand that folks with different levels of intelligence quota can have very different adaptive functioning levels, and our diagnoses are more accurately reflective of how someone functions, what their ability to assess risk is, what their understanding of cultural standards are, can they hold a job, how socially interactive are they, these types of things. It's a little bit more nuanced than it was. So the severity is based on adaptive functioning. The onset of this diagnosis must have occurred during the developmental period, and any F prefix diagnostics, these are basically your big picture psychiatric diagnoses: major depressive disorder, generalized anxiety disorder, PTSD, schizophrenia, bipolar, all the big ones, right? It's important to remember that these diagnoses, the way that their diagnostic criteria are written, is intended for neurotypical patients. At least that's the population in which these diagnoses were established and studied. So individuals with intellectual disabilities can have a very different presentation of their symptoms of depression or of their symptoms of bipolarity or whatever the case may be. And that's something we'll discuss in this topic as well. So the diagnosis of intellectual disabilities, 85% of folks with ID fit into the mild category, and we'll discuss these diagnostic levels of severity in terms of conceptual, social, and practical terms. So conceptually, people with mild intellectual disabilities have very few differences pre-academic, that is, prior to being school-aged. Once school-aged, they will reflectively have some academic difficulties and need some support, but many of them can complete high school with educational support and go on to take college courses and complete college coursework and get degrees. Socially, they tend to be immature as compared to their peers. They have more concrete communication and issues with emotional regulation that is reflected in their need for additional support in the educational environment. Practically, they will have good personal care. They may need some activities of daily living support, that's ADL, with cooking, money management, etc. But mild ID is a very wide slice of folks with ID. Folks can be entirely independent, frankly, or need some degree of support, and it can be varied. So next, let's discuss folks with moderate ID. This is 10% of the ID population approximately. Conceptually, they have slow language and pre-academic skill development, and there will be some marked limitations in their school performance. Socially, they tend to have simplistic spoken language and limited relationships and social judgment. It's very notable when you interact with a person with moderate ID. Folks with mild ID have very good social masking often, and upon initial interaction, you may not perceive them as being any cognitively different from anybody else. Folks with moderate ID, it's very apparent. They tend to be more egocentric, and that's not like a narcissism comment. It's more, they tend to find themselves in Piaget's pre-operational stage. So this is the developmental stage that Piaget assigned children in the 2 to 7 year range. So if you reflect on what you understand a 2 to 7 year old's understanding of themselves and their world to be, this can be reflective of the folks with intellectual disability in the moderate range as well. Practically speaking, activities of daily living may be okay in folks with ID that is moderate, but extensive training for age-appropriate skills is needed, and they need a lot of support on the job. Next, let's discuss severe ID. So conceptually, this 3 to 4% of folks with ID, they really have limited skill attainment. Their social interaction is very limited, generally single word and limited to here and now focused speech. So on the tasks in front of them being addressed at that moment, there's very, very little ability to abstract anything. Practically, folks with severe ID need support for all their activities of daily living, if you think of it that way. Toothbrushing, hygiene, clothing, need a lot of assistance with any of that. They may be independent in recreation, they may be able to entertain themselves, but will be unable to make responsible self-care decisions in most cases. 1 to 2% of our ID population have profound intellectual disability. These are individuals that are very reactive to their environment. They have kind of a purely physical rather than symbolic understanding of their environment, very functional use of objects that can sometimes be limited. Socially, they are largely nonverbal, but may have symbolic communication with either grunting or symboling with their hands. Gestures is their primary method of communication. Practically speaking, folks with profound ID depend on others for their physical care, health, and safety, and they often need support even in recreational settings. Okay, so that was our first topic. Next, we'll move on to understanding the ID interview per the DMID. It's a good action shot there. Okay, so Szymanski and King are co-authors of the 1999 edition of the DMID. I really like this statement from there, so I'll read it to you real quick. There is universal agreement that all individuals with ID might present with behavior and interaction skills of a chronologically younger child and might maintain these characteristics throughout the lifespan. Thus, any judgment about symptom presentation must be evaluated within the context of developmental delay. This is to say, people with intellectual disability present in a particular fashion, and it can be highly individual to from one person with ID to the next. They're highly individual people and have highly individual presentations. So there's no uniform carte blanche that you can give to understanding this population or every individual in this population. And when evaluating them, you must understand the person's baseline functioning, their baseline ability to convey themselves, to communicate, to not assume that what you're seeing is pathology or something that's quote unquote wrong, rather than, hey, this is how this person typically functions based on their developmental level. And what we are seeing is not a divergence from that, versus this is markedly different than how this person was several months ago and probably indicative of some kind of illness they're experiencing. So here are some diagnostic challenges that have fancy names, but we'll go through what exactly they mean here in the following slides. Intellectual distortion, psychological masking, cognitive distortion, and baseline exaggeration are diagnostic challenges set forth by the DMID when dealing with this population that are important to bear in mind when you're trying to carry out an interview. So intellectual distortion. Robert Sovner is a very wise man. In 1986, he wrote about these particular characteristics in a really easy to understand way. So I wanted to bring those to the table here. Sovner wrote, emotional symptoms are difficult to elicit because of deficits in abstract thinking and in receptive and expressive language skills. So this is what's referred to as intellectual distortion. We'll talk a little bit more about that. So intellectual distortion refers to diminished abstract thinking and communication skills that are limiting the ability of the person to accurately and fully describe emotional and behavioral symptoms, aka folks with ID don't always communicate the same way that neurotypical people do. And this is largely based on their decreased ability to think in the abstract, to take concepts that aren't in front of them in time and space and understand their role in their lives or in other people's lives. Here's a good example. Patient with ID may answer yes when the clinician asks if they hear voices. This is like practically true. They are hearing voices. They hear their own voice, they hear your voice, and if not further investigated and if not understood in the context of this individual's baseline understanding, you may come away with the presumption that they are responding to internal stimuli, when that is not at all the case. That's one example. Psychological masking is the next thing set forth by Sovner. Limited social experiences can influence the context of psychiatric symptoms. So, limited life experiences, social skills, and intellectual capacity can influence the content of psychiatric symptoms. These symptoms may be easily missed because they might seem normal for a neurotypical individual in the general population. So, for example, a manic patient with moderate ID believes they have a girlfriend, they talk about having driven their car recently. In the context of understanding that they live in a group home, they need, with moderate ID, they even need ADL support, you know they're not driving. So though your neurotypical patients might report these activities and have them be very typical and understandable, this is a aberration and a delusion of grandeur in this patient's case, which again comes back to the previous point I made about like you really need to understand the person's baseline in order to be able to differentiate these types of symptoms if they do present themselves. Cognitive disintegration refers to the decreased ability to tolerate stress, leading to anxiety-induced decompensation, which is sometimes misinterpreted as psychosis. So, cognitive disintegration, again, is the impaired ability to tolerate stress, leading to anxiety-induced decompensation that can lead the individual to appear bizarre, psychotic, or somatic. So this is something that a lot of us have probably experienced. You have an individual with intellectual disability or developmental disabilities, they move to a new environment, and that causes a very distinct difference in their behavior. Well, they just moved from one group home to another, but the titanic shift in the context of that person's life is as if, you know, the world is being obliterated in their minds, you know. So a patient with IED who recently moved to a new group home starts reporting a new imaginary friend. This could be considered normal behavior for IED, though it may be considered bizarre for an individual in the general population. So folks with IED are highly individual and may cope with stress, with sorrow in ways that aren't stereotypic. And this is one good example. Baseline exaggeration. And this is not to say like I'm exaggerating, I'm over-reporting something. It's more whatever a person's baseline function is may be amplified. According to Sodner, he breaks it down as basically an increase in severity or frequency of chronic maladaptive behavior after an onset of psychiatric illness. So pre-existing maladaptive behavior not attributed to mental illness may increase in frequency or intensity with the onset of a psychiatric disorder. That's a lot of words to say. Basically, somebody who has aggression at baseline, for instance, which is controlled well with behavioral techniques and redirection and counseling, suddenly presents with a lot more aggression when they're in the midst of a manic episode. Neurotypical patients with mania, you know, are stereotypically pretty aggressive, but not all the time. Sometimes they're just highly energetic and highly delusional. But whatever is present in a small percentage in somebody with intellectual disability, when they are distressed or when they are experiencing an episode of psychiatric illness, may be much more amplified than it was previously. Okay, so next we're going to move on to one of our more robust sections in the presentation, which is basically discussing the intellectual disability interview and principles and techniques to observe. Speaking of observation, when interviewing an individual with intellectual disability, observation is a key component of this interview. So when someone has mild intellectual disability, your interaction with them in a diagnostic sense, in a day-to-day sense, may be nearly the same as it would be with anybody else that you see or interact with. As the intellectual disability grows more severe, however, it becomes very, very important that you watch the patient as much as listen to them. In severe and profound IED, people's behavior, people's tendencies, and slight changes in their stereotypic patterns of behavior are very, very important to be observant of. In my job, talking to patients' care staff, to their SSAs, to their behavioral specialists, to the house staff is extremely important. I see a lot of folks that have pretty significant disabilities, and if left up to just them, they wouldn't be able to report necessarily everything that it is that I need to know to take the best care of them. So not just observing them, but also observing their environment and relying on collateral information, which we'll talk more about a little bit later. So let's look at an example of this. So here we have a nonverbal patient. This has been made anonymous, so this is an individual very similar to someone who I saw recently. A 52-year-old male with a history of profound IED. Again, that's 1 to 2% of the population. Autism level 3, which is the most severe form. Cerebral palsy and complete vision impairment, aka blindness, presents to clinic. For 4 months, he has exhibited agitation, verbal and physical aggression, chanting, kind of non-interpretive, but like grunting, kind of rhythmic chanting, kicking, self-injurious behavior, he was biting himself, and property destruction. He's also begun gagging himself and has shown a decrease in his activities of daily living, the things that he's able to do on his own. So a regression in that regard. We've noticed a decrease in his appetite, and over the past few months, he's lost 13 pounds. He started to consume inedible items, pieces of blankets and clothing. When I first examine him, he is rocking very intensely. So we'll come back to that case example a little bit later, but let's talk about everything that was reported in that case and break them down to kind of their concerning components, right? So let's first talk about aggression, especially self-injurious behavior, aggression to others, things like that. This is the most common reason that a psychiatrist is consulted for a patient with intellectual disability. It can be for a very, very large variety of reasons. Aggression is not always a problem with thought content or a thought disorder, or not all folks with intellectual disability who display aggression are psychotic per se, though that can sometimes be the stereotypic thing that is reported. Aggression is a means of expressing frustration for folks with ID a lot of the time, or it can be a learned problem behavior. As I mentioned before, 90 to 95% of the population have experienced neglect or abuse at some point. Aggression can be protective, and some folks have learned that this is the only way that they can remain safe, or that people will give them what they want if they display aggression. And obviously, if that is a learned behavior, it needs to be unlearned, and that can be a very challenging thing to undertake. Aggression can be a means of communication. It can be a signal of an acute psychiatric problem as well, as in mania, like we discussed before. In situations of stress, pain, change in routine, or novelty, aka being presented with a new challenge or a new person, whatever is baseline may be exaggerated again. So if there is some aggression, it may become amplified in these cases. One important thing that I always want to bring up in my role as a physician, right, is that folks will be aggressive in many different contexts. And one of them that I always like to think about is that it may be an expression of physical pain or an expression of an acute medical condition. And that should always be something that we're bearing in the back of our mind. We'll talk more about that later. Headbanging. All right. Some people can do this often, but I want to reflect that this is not a normal behavior and should never be just accepted as, oh, that's just what he or she does. Headbanging and the symbolic kind of association, if you think about it, sometimes people have bad feelings in their head. Sometimes they hit their head to try to get them out. Sometimes it's because they literally have bad feelings. They have head pain. So they will strike their head to deal with a headache, to deal with dental pain. Headbanging or rhythmic movements like that, like rocking, can be associated with seizure. So many folks with intellectual disabilities have seizure disorders as well. So to ensure there aren't other stereotypic symptoms of seizure going on. Otitis or mastoiditis, that is a infection in basically your ear canals, so an ear infection. Sinus problems associated with that. And then tinea capitis or lice, that is like a fungal infection of the scalp, or having bugs in your hair, so to speak. So these conditions can all result in somebody headbanging as a means to cope with it. It should be taken into consideration in those contexts. Intense rocking, like in our example that we just discussed. So this again is not quote unquote normal for anybody with ID. Sometimes it can be a self-soothing behavior or a self-stimming behavior. And isn't necessarily reflective of anything the matter, but it should also be taken into context that if people are self-stimming or self-soothing, it's probably because they're distressed. So depression, anxiety, and medication side effect. And this can be reflected on headbanging as well. Any rhythmic behavior, self-injurious or otherwise, can be associated with some of the antipsychotic medications that we prescribe for folks, especially when they're aggressive. When you change the way that dopamine works in the brain enough and too heavily, sometimes it can induce problems with movement or repetitive rhythmic movement. And understanding where the patient came from before medication change and how significantly they've changed since then is really important for correcting that. Visceral pain, that is to say pain in the gut. So stomach pain, digestive problems, constipation, especially in our population, who have a hard time reporting issues like constipation and are very prone to eating low fiber foods and processed foods. Constipation can be a problem. So knowing when our friends and when our patients have had their last bowel movement can be really important for understanding where this particular pain is coming from. Headache again, or scalp fungus or lice. Okay, so what are some limits on communicating with folks with intellectual disabilities? So like I mentioned before, observation is critical. What physically are we seeing? What behaviors are we seeing in the individual in front of us? What is their degree of relatedness? How good is their eye contact? How good is their reciprocity in conversation? And again, all of that is predicated on understanding what the person's baseline is. Because, well, he just never makes eye contact and he does not speak is good to know, because that would be a shocking thing to walk into a room and see that somebody's doing for the first time. Just the last week they were speaking and interacting and making good eye contact could be symbolic of a very, very significant problem if that was not stereotypic for the person. Expression of affect. Some people with ID have a very blunted way of expressing emotion. They do not display emotion in a typical fashion or the way that you and I might. Folks with autism in particular have a very blunted way of reflecting emotion. They may not be as overtly happy, overtly reciprocal in conversation, as overtly stereotypically sad, the way you'd expect someone to cry and do things like that. So all these facets need to be taken into account. Impulse control is important to gauge. How in control of their own faculties are they? Are they able to restrict themselves from taking action immediately that they would want to otherwise? Are they able to deny themselves instant gratification in order to get a benefit in the end? Folks with more severe ID have issues with impulse control, but it can also be associated with several psychiatric diagnoses. What is their attention span like? Are they able to hold, are you able to hold their attention for long enough to get a full question out even sometimes? Can they listen to an entire question stem and understand the intent of that question? This can be very important to assess as well. So their activity level and then any unusual or repetitive behavior that they might have displayed recently can limit your ability to communicate with someone with intellectual disability in a productive fashion, unless you understand the context of those factors. So let's go back to our nonverbal patient we discussed before, having been over all of those characteristics. So I've made some words bold here. So our 52-year-old male with a history of profound ID, he's been displaying aggression. All right, and that's the stereotypic thing that a psychiatrist is consulted for, right? But this has been for the last 4 months. Prior to that, there wasn't much aggression to speak of. He's also been gagging himself. All right, so that's a pretty big difference and likely associated with something to do with the mouth. He has a decrease in appetite. He's lost weight. So why would somebody be doing that? I imagine that either eating hurts them or digesting hurts them. And on examination, they're rocking. Okay, so a self-stimming, soothing behavior. Spoiler alert, right? In the end, we found that this individual had a dental cavity. And after he got to the dentist, which was challenging for an individual with profound ID who was being aggressive, right? After we got him to a dental appointment and they corrected the dental cavity, all these behaviors corrected themselves. Consuming inedible items, like why is he eating blankets? Why is he eating clothing? He's never done that before, was his demonstration of my mouth hurts. I'm putting soft things in there to try to make that feel better, essentially unable to communicate the way that you or I might, his distress and his pain. All of these behaviors had come out of that and had grown worse over the course of 4 months. You could see how an individual like this might just have gotten put on a really heavy medication regimen, having all of his inedible items restricted from him. You know, he's biting these now, he can't have those. Those types of approaches could have been really harmful to the patient and wouldn't have corrected the underlying problem. So that is one example of such a case. So next, I'd like to talk about the BPS format, or the biopsychosocial format. This is the standard way that most mental health folks will formulate a patient's presentation. It was developed by George Engel in 1976 and takes into account basically the biological factors, the psychological factors, and the social factors that are surrounding somebody's presentation. In ID, we take that into consideration, plus a developmental formulation, which is a good way to think about these individuals and how to conceptualize them completely. Generally, this interview will consist of an interview with the patient, then an interview with the patient and the caretaker or the individuals by themselves, and then a source of collateral, either the parents of the individual or their collaborating agencies or SSA, et cetera. That way you get kind of the full picture. Sometimes staff will report, you know, she's so tired in the morning, she can't interact at workshop, and we're having a real problem with that. And then mom, who sees her on the weekends, is like, no, she's fine. She's fine all weekend long and has no problems. Like, well, there's a big discrepancy. Let's figure out what's going on there. So that's why different sources of information can be important. So BPS, again, let's talk about the biological factors first. So 85% of folks with ID have untreated, undertreated, or undiagnosed medical problems. This is from Ryan et al. In 2003. So this is an allusion to the previous case we brought up. This is very commonly an issue that presents itself. Dental pain, sinus pain, digestive problems, urinary tract infections can cause huge changes in folks with ID's baseline behaviors. So these problems are often worsened by the restrictions on care that these folks experience. It's harder to get them to get blood work. It's harder to get them in for office visits, particularly with COVID. My goodness, it was really, really difficult to get in to see a specialist like a neurologist or a rheumatologist if folks had those problems. Medications are often used in this population in ways that they weren't intended to be used, sometimes in unsafe ways, unfortunately, with monitoring protocols that aren't to the stereotypic standard. So, you know, you put somebody on lithium, for instance, you put somebody on an antipsychotic, they will often in the early interval need monthly lab monitoring, if not more frequent lab monitoring, at least for the first interval to assure that there isn't any organ damage occurring and that their blood levels don't get too high. But that can be extremely challenging to get done with a person with intellectual disabilities. So it's always important for us to assess, biologically speaking, hey, what patterns have we seen with medications in the past? Which medications have produced similar responses in folks? And have they had paradoxical reactions, okay? It's very typical for like benzodiazepines, for instance, right? These are sedative medications. You might give me a benzodiazepine like Ativan or Xanax and I will fall asleep. You know, that would knock me out. Sometimes folks with intellectual disabilities can have the inverse reaction. They become much more agitated when given sedative medications because of their perception that they're sleepy, and when I'm sleepy, I'm in danger, might be their association. So it's very important to understand, hey, we shouldn't try this medication if it's like those medications because it could create a bigger problem. It's also very important to understand what our folks with ID, what their sexual activity is like. Unfortunately, as aforementioned, people with ID and developmental disabilities can be sexually trafficked, they can be sexually mistreated, and they can also be in consensual sexual relationships. So it's important to understand in that context whether they have birth control, if they're having safe sex, if they understand their bodily autonomy in those regards. So very important thing to discuss. Also caffeine and sugar consumption. Obviously, drinking 3 Monsters a day or a whole 2 liter of Mountain Dew, that's a lot of sugar and it's a whole lot of caffeine and can cause caffeine withdrawal headaches and can cause issues with bowels and bladder, right, when you're drinking that much fluid. So, all right, moving on from B to P of the BPS, the psychological factors. So it's important to understand folks with ID what their significant relationships are. The most important person in many of my patients' lives are their mother or father, who they get to see sometimes daily if they live at home, or weekly or bi-weekly if they live in a group home setting. Sometimes this is a caregiver that they've had for a long time in the home, or other primary care staff. And if that person retires or moves to a different agency, it can be devastating in a way that a neurotypical person would be able to bounce back from, who has more myriad social relationships. So understanding the gravity of those types of relationships to our patients is very important. Also reflect that they're a very highly traumatized population, and in a neurotypical patient, trauma and PTSD can take on a complex and atypical presentation in we neurotypical folks alone, but people with intellectual disabilities can have a completely different presentation of those same diagnoses. Behavioral specialists, what behavioral specialists have the patients interacted with in the past, what interventions have been successful, how far have they come from where they were at their baseline to now. Also, sometimes it can be stereotypically kind of an assumption that folks with ID or DD, developmental disabilities, they can't benefit from therapy, like what would the point be? And that just simply isn't true. Skilled therapists who are used to working with folks with ID can make huge headway in understanding folks' trauma and their depression and their anxiety, and doing CBT with folks to help them work through automatic negative thinking and automatic negative assumptions of themselves. Even folks with moderate to severe ID can benefit from having a therapeutic person in their life to do consistent work with. So, social factors. This is particularly important in my work. What county does the individual live in, right? This is not an important question to ask your neurotypical patient generally, but for folks with ID, it dictates a lot of things. Where do they live? What group home are they associated with? Who's their SSA? Where do they get their services? What day programs are available to them? What funding is available to them is extremely important. So sometimes things that aren't stereotypically necessary to ask about in a lot of other populations can be paramount in folks with ID. What's their housing situation like? Do they live at home? Are they in a group home? Are they in an apartment with partial day staff? Do they need 24/7 care? What are their entitlements to services? And what use of resources do they have? I always want to know about work and school programming too. I think that particularly during COVID, some of our folks with ID got really isolated. And that's not good for you. It's not good for me. It's not good for anybody, particularly not somebody with intellectual disabilities whose entire world can be 8 to 10 people. When half of that is cut off, it can be extremely isolating and difficult for folks. Understanding what their social network is like, understanding what their spending money is like, what they spend that money on. Sometimes it can be very difficult. Folks want nothing but to spend their money on cigarettes or sugary drinks. These are substances that are readily available at any gas station. It's hard enough to resist a sugary drink for those of us with a lot of impulse control, but man, something laden with caffeine and sugar in the context of having not the best impulse control can be so challenging for a lot of our folks to resist when they have intellectual disabilities, and now they have diabetes and they've gained a lot of weight and they're really struggling with some health issues as a result of that. These can be difficult things to navigate and important for us to know. So how do you set the stage for these interviews? Well, do your homework, know what the background of the patient is, know what their, where they were raised, where they've been before, what struggles they've had and in what contexts. This is extremely important because a lot of times our patients can tell us a lot, but sometimes they can't. Sometimes they have a lot of communication issues and we need good collateral for that. If I do a patient intake and a person has really limited ability to relay information to me themselves, for whatever reason, and we don't have good collateral, I essentially can't really help that person in the best way. So that's an extremely important piece of our interview. Setting the stage is important. That's to say, making sure that the patient understands who you are, what your role is in the care team, because a lot of folks have had really difficult interactions with authority figures or really difficult interactions with interview style settings. And that's when they're getting in trouble usually, or that's when somebody is going to take something away from them, or that's when they've been bad. And it's sad, but it's true for a lot of folks. So understanding that context and understanding why they might be reluctant to interact with you in a forthcoming way is important. In general, folks with ID have better receptive language skills than expressive language skills. That is to say, they will understand you better than they will be able to tell you how they understand you. So one should always assume that the patient can understand you. Never presume that you're being misunderstood unless that is very evident, because generally the receptive language skills are better than the expressive. Specifically point out some words or questions that may be difficult to understand, and make sure that we ourselves take any responsibility for miscommunication. Obviously, and unfortunately, folks with intellectual disabilities are used to being told that they're not picking up on things, and they're used to being left out of certain nuances or details of conversations, or being ignored in those contexts. And it's sad, but it's been true in school for folks, it's been true in their home environment sometimes. And taking the onus of miscommunication on we ourselves and saying that it's okay to tell me if you don't understand something, it's okay to say I don't know, for instance, can be a really great opportunity for some folks with ID who over a lifetime of being told that they're not as smart as other people or not as capable of other people can sometimes make regular the acquiescence approach, which we'll talk a little bit later. That is to say, yep, I disagree with everything that's being said because I don't want to be honest about the fact that I don't understand certain aspects of that, because then I get asked more questions and then I get told that I'm not smart or something like that. And that can be an important thing to be keyed in on. So start with non-threatening general questions in the interview, and then lead to more sensitive or probing questions towards the end of the interview once some rapport has been established, once the patient understands that they're safe, that you're not a threatening person, that you're not looking to discipline or punish them. And always arrange for privacy. Often, I'll get on an interview and there are 5 people in the room, right? All the care staff, the patient themselves. You always want to allow for privacy with your patients. They are human beings in as much as any of us are, right? And they should be allowed and afforded privacy to discuss things with their care staff and their physician. Okay, so question formats. Let's talk about some. Yes and no questions with follow-ups are considered to be a good approach. So like I said, folks with mild ID can, in a lot of contexts, have a typical conversation with you and answer questions in a typical fashion. Sometimes patients have a lot of trouble with that, and assessing that can be part of the challenge of our diagnostic interview. So if you ask, a question up front, for instance, do your teeth hurt? No. Okay. Coming back later in the conversation to that same topic, as they continue to touch their mouth or are digging around in their mouth while they're talking to you, is there anything going on with your mouth? Yes. What's going on with your mouth? Now we're moving away from yes/no question format to a more open-ended question format, like, tell me what's going on with your mouth. And he's like, oh, my fingers are in there. Okay, so now you're getting a concrete answer to your question, right? It gives you a lot of information about the person's receptiveness to your communication and also their ability to move forward with questions if you touch back on something that you have been given the answer to earlier in the interview, later in the interview. Multiple choice questions sometimes will help folks, especially if they can be written down, to set up a list of options with anybody with memory issues, because you might get kind of a serial position effect, which we'll talk about a little bit later too, where when given 3 options, you are always answered by the final option, because that's the option the patient remembers. Because do you like red, blue, or green candy, right? Oh, it's green. All right, well, is your favorite day of the week where you go to workshop Monday, Wednesday, or Friday? Oh, it's Friday for sure. Okay. Note if that's the case every single time, because they may just be so fixated on your question, just trying to answer it right, that they answer whatever is most proximal to the question being completed. Either or questions are same as yes, no, in that they give the patient 2 options and are more straightforward for folks to answer. And again, serial position effects are important to keep note of. Here's some basic cautions in interviews, okay? Yes, no questions, great way to interview somebody. Very helpful for folks with more pronounced symptoms. But questions like, do you use drugs? That's going to lead to a singular answer a lot of the time, particularly if there's staff in the room, and I think we all understand that. Double-barreled questions. Do you like your home and your staff there? Well, I like my home, but I don't always like my staff because they're mean and make me do stuff. But I'm just going to say yes, because that's a complicated question, and you asked me about my home, and I suppose it's fine. It's better than when I was homeless. It's better than when I was neglected, right? But there's a lot of nuance that will be missed in a person with ID if these questions are approached in this fashion. Long, multiple questions, and I can be guilty of this when I get flustered in an interview and I'm trying to ask multiple questions. Do you like your job or don't you? And what do you think about your supervisor and coworkers? Wow, that's a whole lot. You know, a person with abstract capabilities would be able to give you a gestalt kind of understanding of that whole complex relationship. What do I like about my job? What do I like about my coworkers? But someone with ID might struggle with that. And then leading questions. You knew that you weren't supposed to do that, didn't you? And in some stereotypic examples, I've seen interviewers gesture, and body language is very important, you know. You're not having any troubles at home, are you? Ensuring that our body language remains neutral so that our patients feel as comfortable answering honestly and not needing to acquiesce with us is also important. So avoid the following question types: random probing, coercive questions like, you wouldn't want to lose your outing, would you? Embarrassing or accusatory questions: how often do you hit other people at work? Or why questions. Why did you hit your roommate last night? Is going to be embarrassing for the patient and won't often give them the best opportunity to answer in an honest fashion. What happened last night might be a good way to open that up. Does your roommate make you mad? Yes or no, right? Is a more simple way to approach the topic that you want the answer to without making the patient feel backed into a corner. Open-ended questions, like we've mentioned before, they require a greater cognitive and linguistic capability. What do you do for fun when you are by yourself? I like movies. Okay, what else? What else? What else? You know, continuing down until you give them the opportunity to talk about, it might not occur to them all the things they like to do right off the bat, but with serial questioning of the same question, you're going to get lots more data points that somebody who's neurotypical might be able to deliver all in one fell swoop, all their hobbies, right? But it can be a lot to try to remember all of that when you're a little nervous in a conversation. So here's an example. How do you get to work most days? And this is the percentages you see are the honest answer, okay? So with these respondents, we understood what the actual answer to the question was, but when asked, how do you get to work most days, 73% gave the honest answer. The remainder, it was some fabrication or not exactly the whole truth. A follow-up question: do you get to work by car, by bus, by walking? You know, these are yes/no questions. By some other method, more open-ended. 94% of respondents were able to respond with the truth. And this is not intentionally misleading us. This is simply what occurred to them to talk about at the time. Using pictures with these above questions, again, another adaptive question technique, was 100% successful. So engaging not only verbal, but visual memory and logic is helpful in these approaches. So some folks have issues with language. People with intellectual disabilities have difficulty describing references in an unambiguous fashion. A lot of communication can be fairly concrete. And this is particularly true when retelling or creating a story about something or creating a gestalt image of a memory. So look out for that. Coping with language issues. In general, using short words and short sentences can be helpful. Plain language or language around a 6th grade level. Now, this is all important to take into context that there are folks with mild ID who essentially, you know, they are in college. They're collegiately capable, have bachelor's degrees. This would not be an appropriate approach to a patient like that. We're talking about your stereotypic lower functioning mild patient to moderate to severe. Using single clause sentences that are asking one question at a time, using active verbs rather than passive ones, and making sure that things are in a personal context. So contextualized to the patient and their experience specifically, especially with folks with moderate ID who have a difficult time thinking outside of themselves and not thinking in an egocentric fashion, aka the world revolves around me and all actions that take place are my fault or a result of something that I've done. Using present tense whenever possible and using time anchors when considering past events. This is to say, okay, when was the last time you saw your doctor? You know, your primary care doctor. I think it was last month. Okay, was it before or after your birthday? This patient really likes their birthday. Oh, it was before my birthday. Okay, well, your birthday was in April, so that was probably a few months ago. Yeah, I guess it was a few months ago. That might be one example. Coping with inattention. So if a patient is clearly inattentive, if they have a diagnosis of ADHD and have difficulties with focus, frequently review and summarize what has been said in the interview. This can be helpful for anybody, obviously, it's helpful for me. Refocus the interviewee, allows them opportunity to add detail when you reiterate a previous question, allows the opportunity to disagree if we, the interviewer's interpretation, is incorrect about a component of the interview. Consider multiple sessions if needed. Some folks need more than just an hour to be understood and to be fully heard. So that's important to reflect on. Research indicates that multiple trials increases the consistency of results, aka if you run up one question stem and approach it multiple times, or approach it in separate interviews over the course of several weeks, if you have multiple opportunities to speak with the patient, you will get a more consistent answer and a more honest answer from folks than if you pit them to answering these questions one at a time. So let's talk about acquiescence. This is something I referred to previously. This is the tendency for folks with ID to just agree with statements that are being made. This is negatively correlated with IQ, aka folks with lower IQ tend to acquiesce more readily, okay? They will just agree with what is being said rather than give, quote, the honest answer because of their perception that disagreement causes them problems or causes them to be at risk. It's more common if the interview is viewed as an authority figure. A lot of the time, me doing telepsych, I'm just some guy on the computer. You know, I'm not a person that shows up in their home. I'm not a person that they've known for a great consistency. I'm not parental in that regard. So I forego some of that, but people's experience with physicians can vary, of course. It's more common with comprehension problems or social desirability as well. So folks that have more ego strength and more understanding of themselves as an individual rather than that pre-operational kind of Piaget stage, they will want to fit in and they will want to be liked. And sometimes this can lead to this acquiescence as well. So how do you cope with this? You can use either or multiple question formats. You need to pay attention to serial order effects like we talked about earlier, always answering with a certain numbered answer because of its proximity to the end of a question stem, or particularly an emphasis on whatever the latter option is, which is serial order effect. So avoid the temptation to use either or formats that can be a bit much for people to track. So how do you cope with serial order issues? You can always mix up the order. So are you happy or sad? Are you sad or mad? Are you mad or happy? You're going down a stem there. And if the answer is mad, you're going to get mad twice. You know, you won't get two separate answers to those questions. Follow-up responses to either or questions with requests for further examples of elaboration. What else? What else? Kind of like that previous question stem we talked about. Serial order appears to be the greatest threat in response to yes/no questions. So, yep, it's always going to be yes for acquiescence, or it's always going to be no because I happen to answer whatever the second item is. How do you cope with memory issues? So, assess memory informally by asking questions about which you have the answer. Okay, when was the last time they went to the monster truck rally? When was the last time they went to the strawberry festival? Well, you know that was last year because you talked about it before. Now the goal is to establish if the patient can recall that as well. Understand that memory declines as a recall period increases, and use time anchors like I mentioned before. Their birthdays, holidays, significant life events, etc. Interviewing folks with their collateral sources and with third parties, with care staff can also really help this accuracy. So here are some additional considerations. Here's a myth. I can't get good information from a person with ID. Well, they might have trouble communicating what happened. They might have difficulty remembering the order of events. They may have difficulty with naming people, places, times, or giving consistent responses. The truth is that anyone can have trouble with these issues. Folks that are neurotypical just are better at concealing it. Don't avoid interviewing a patient just because they have difficulty with one of these issues. It is a stereotypic problem that all of us have, and it should just be navigated compassionately. Subvocalizations, what is this? Well, sometimes I'll ask a patient a question and they'll look down and they'll be mouthing words to themselves with a furrowed brow. Or they'll talk out an answer under their breath and then give it at a higher volume to me. All this is, and it's stereotypic, is a vocalization of their thought process, hearing what they're thinking. They're rehearsing what's going to be said or practicing it, and it's not a stalling tactic or an attempt to lie. And it's not the same as talking to oneself from a psychiatric perspective, as in a hallucination or in thought disturbance. Saliency is the emotional strength or pull of an experience or information, something that puts the individual on alert and is high in personal relevance. The saliency of information helps all people remember things, good or bad. The saliency of common events may be greater for individuals with ID, aka the monster truck rally. That's a big deal, right? But just going outside for a walk might be the best thing that they do in their week. Certainly spending time with their parents can often be the best thing that they do in their week. Getting pizza, the number of times people enthusiastically report to me the next time they're going to have pizza is really high. So recognize the saliency of those events to your patients. If you know what is salient for the patient, you can link that to information to the event and behavior of interest, i.e. food, like I mentioned. So let's talk about various, I know we're running short on time, I'll be quick, but I know there's various forms of ID out there and they need different approaches. So we'll talk about that real quick. Here we have some folks with Fragile X. Folks with Fragile X have an indirect style of verbal expression. They often make limited eye contact or sit in an angle to the interviewer and clutter in their speech. This means they have pauses in conversation that are too short, too long, or in the wrong places. They often correct, revise, or interject in their speech, and this is not stuttering. Stutterers know what they want to say, they just have a difficult time articulating it verbally. Cluttering in Fragile X is different than that. They avoid eye contact. Fragile X is very commonly associated with autism spectrum disorder as well, so you can see some of those stereotypic symptoms pop up in both. Echolalia, the tendency to repeat what has been said in a mimicking kind of fashion. You might ask a question and they'll say the exact question back in your same tone of voice. Staccato speech, that is rhythmic kind of punctuated speech. And an unusual response to sensory stimuli as seen in autism spectrum disorder. There's also this stereotypic thing called the Fragile X handshake, where they'll shake your hand but make no eye contact while doing it, which is not a neurotypical maneuver. And you'll see a lot of perseveration, that is automatic phrases and a sticking to a single topic for long periods of time during the examination. Down syndrome. Folks with Down syndrome really need early interventions in order to acquire new information because it'll slow down during their developmental years. Folks with Down syndrome have particular difficulty with who, where, when, what questions and irregular past tense questions, and sometimes can have a hard time with pronunciation just because of their large palates and thick tongues, and will have difficulty with hearing or oral reproduction of certain sounds as a result. Here are some final thoughts. We're getting to the end of the hour here. First and foremost, always establish an alliance with your patient. When you're able to collect important diagnostic data from the patient while making them feel at ease, you're going to get a more accurate amount of information. Recap, summarize, and paraphrase, like we talked about. These are high-yield techniques. And remember that success is not measured in the form of a diagnosis or a medication or a list or a behavioral support plan. It's reflected in the comfort that the patient can feel and in providing the best care for them possible. Educate yourself through increasing your cognitive knowledge base, increasing your experiential knowledge base by working with these folks more often. This will lead to better interview and investigative techniques. Recognize that there really is no cookbook approach to folks with disability. They are as unique and variegated as any neurotypical person and can certainly have their very own quirks and tendencies. Everything is individual. Use who, what, when, where questions rather than who, what, where questions rather than when, how, and why questions with these folks, and recognize that some of those question stems may be difficult for folks with Down syndrome, like we mentioned. Speak directly to the person. The tendency can be to speak to the care staff the entire time for a lot of folks who interact with patients with ID, but recognize that you'll gain a lot, both in terms of rapport and comfort from the patient in interacting with them directly. Use assistive devices like picture cards, like we talked about earlier, or if hearing is an issue, hearing aids. It can be very important to be able to carry out an interview successfully. Collateral information, particularly in more severe patients, is extremely important from all the sources they interact with. Here's the outline of what we went over today in the 4 main topics. Thank you for your time today. Just so we're all aware, here's our sponsor, and thank you for Mental Health and Addiction Services of Ohio for sponsoring this talk. I'll take any questions at this point.
I just wanted to point out, we don't have any questions in the box yet. I assume people are probably typing. But Tina did ask about the slides. If you haven't located those are in the handout section of GoToWebinar, so you should be able to download those as well as a summary of Dr. Close's presentation.
I also have my email on the slide there. You are welcome to email me any questions or concerns you have. Here we go. Can you talk a little bit about interviewing a moderate ID person with reactive attachment disorder? Yeah, thanks, Cheryl. So reactive attachment disorder is a extremely significant trauma disorder that is generally associated with childhood abuse or neglect. Folks with RAD can have a really difficult time with trust and a very difficult time with authority figures. They tend to attach aggressively to someone and then reject them in a very paradoxical kind of fashion. Oftentimes, when I first interview somebody with reactive attachment disorder, they are so positive and fawning and towards me, but they've been giving their care staff absolute heck, for the last couple of weeks preceding that. The thing about reactive attachment disorder, in its similarity to borderline personality disorder, is that folks can often be their own worst enemy. The desire in the heart of most people with reactive attachment disorder is to establish caring, nurturing relationships. But their behavior runs contrary to that. They tend to alienate people, they tend to frighten people, and they tend to make themselves into the bad guy, so to speak, right? So I would say that interviewing a patient with reactive attachment disorder, I think it's important that all of the individuals on the care team and the interviewee themselves, are all on the same page, that we're all united in our approach to the situation. We are trying to help you. We're all working towards the same goal. Consistency with someone with reactive attachment disorder is extremely important. So we have our appointments at the same time. You can expect to see the same person. Your same caregivers will be there. They will relay the same message to you. There's no infighting or quibbling, so to speak. The more consistency that's possible in the treatment of somebody with reactive attachment disorder and in the interview of somebody with reactive attachment disorder, the more that you can hope to gain from that relationship. Good question. I also just want to mention, Cheryl, that a moderate ID person with RAD, that's tough. Okay, you're essentially talking about from an interpersonal relations standpoint, like we mentioned before, somebody who's around a 6-year-old, 7-year-old level of functioning, very egocentric, right? They might feel that a lot of what's going on is their fault or their responsibility to correct, when honestly none of that is the case. So that is a challenging patient to gain trust with and to make comfortable. So. All right, Brandy asks, do you feel that most MDs shy away from these types of individuals? Let me put it this way, Brandy. I think, and when you speak about MDs, I mean, I assume you mean like anybody from primary care physician to a specialist, to a surgeon, to a psychiatrist. The issue is that a lot of folks with medical degrees just don't have very much experience treating people with intellectual disabilities. Like I said, they're folks with cognitive issues. They're 2 to 3% of the population, and you could easily go through an entire training in residency and not treat very many folks with intellectual disabilities. I would say that in my experience, there are folks that are very, very passionate in the same way that some people would think it would be horribly depressing to work in nursing homes, right? Or work in hospice. Then there are folks who are so passionate about that population, about working with seniors, about working with people who are end of life, despite the difficulty and sadness involved in some of that work. I think that there are people that feel similarly challenged by interacting with people with developmental disabilities or intellectual disabilities, and can be frustrated by the concept of someone who is an adult yet needs support sometimes, in moderate ID cases certainly, like a child might, right? And they have additional care staff and they can't make their own medical decisions for themselves necessarily, so they need, there's a guardian and interacting with them, and it's more work in that way. I was fortunate enough to go to Wright State University for residency, and our faculty there, Dr. Julie Gentili and Dr. Allison Cowan, they're very experienced in working with intellectually disabled folks and have a really good clinic set up. So I got a lot of training, and that helped with the discomfort. But to answer your question honestly, Brandy, I think what you're seeing there is discomfort. Like, how do I approach these patients? They're not like typical patients. Here we had a whole hour-long talk just how to interview somebody effectively in a psychiatric interview, which it's a specialized and nuanced area of medicine. So I think that some people are intimidated by it, to answer your question. Kelly says, it is great that you understand the DDID system and use the lingo. The examples you used were spot on. Thanks for giving us this information. Well, thanks, Kelly. Aw, that's very nice. Yeah, I had really good mentorship in residency, and then just working at Access is a really great opportunity. So I appreciate that. I'm glad I'm not coming across as an imposter. That'd be pretty bad. Alison Klein asks, do you have any ideas of the rates of comorbidity of ID and schizophrenia? I have a high number of clients on my caseload diagnosed with both. I can't help but think some may be misdiagnosed. Oh, Allison, you are bringing up a really good question. So prevalence of schizophrenia in the population is like 1%, okay? Folks with ID, the prevalence is double or triple that, I think, is conservative estimates. But I'm gonna let you in on a secret. People are often misdiagnosed with thought disorders, okay? Because what they have is intellectual disability, and they have the stereotypic presentation of a person with intellectual disability who is distressed, right? He's chomping on a blanket, he's grunting to himself, oof, he's gotta be psychotic. And somebody with less experience with this population would look at that situation and go, oh my gosh, like that person is acting very abnormal. Well, true, but they don't have a typical brain, and they respond to stress, they respond to urinary tract infections, they respond to dental pain, they respond to constipation in a way that makes them seem very unusual. So I agree with you. And to be honest with you, right, I have folks with IED who also definitely have schizophrenia, who are on Clozaril, who were totally psychotic prior to being on medication, okay? We're talking about folks who were nonstop talking to themselves, talking about demons, you know, walking without shoes for miles and miles outside. Those cases are very apparent when they present themselves and can be differentiated from just a distressed person with intellectual disability pretty readily when they're seeing the right person. At the end of the day, though, that person is now on 2 antipsychotics and have been for 15 years, right? And peeling back those medications at that point is something that needs to be done extraordinarily carefully, because people with ID can have very unusual responses to medication, like we talked about, and very unusual responses to stress. So I think particularly 30 years ago, 20 years ago, schizophrenia was the blanket term thrown out to justify the prescription of certain medications, antipsychotics, that might be helpful for somebody with ID, okay? It might be helpful to use Risperdal off-label to assist with some behaviors, or just to assist with irritability, like folks with autism, they can take Risperdal Abilify for irritability and autism. But sometimes these diagnoses were established in order to justify what medications were being applied, when I think pragmatically, that diagnosis might not be the core issue for the patient. Cheryl asks, is there any information you can share about individuals with moderate to severe ID and bipolar disorder who have had severe cases of COVID? Any information on if their symptoms of bipolar disorder are more pronounced severe? So, Cheryl asks a good question. How does COVID factor into these already pretty complicated patients, right? To my knowledge, Cheryl, there's no research that has been done specifically in this subpopulation that you're bringing up. Excuse me. However, COVID and COVID long hauler research is still ongoing, right? We barely, like medically in neurotypical people, understand what the repercussions are. People can have long-standing chronic fatigue stuff, long-standing somatic pain, fibromyalgia type things post-COVID. They can have like bowel and bladder issues that I've seen come out of this, obviously cardiomyopathy and heart problems. And that's just in your neurotypical population. How that affects the neurology and psychiatry of somebody who already has an atypical brain, I don't think we've done formal studies on. What I can say, without being too esoteric, right, is that people with ID have different brains than you and I. People with ID respond to things in ways that we wouldn't assume they would. And understanding the context of that response is important. When they are sick, when they are distressed, when they are fatigued, those things will be amplified. So following an infection of any virus, right, particularly prolonged illness, we can expect that some of these symptoms may be amplified. There's a lot of different models of, hey, bipolarity, where does it come from? How does it grow worse? Schizophrenia, you know, when do these episodes grow more frequent? In general, you know, one of those hypotheses is an inflammatory hypothesis, right? That there is a increase in bodily inflammation, which can set some people kind of off kilter. And a pervasive viral illness is certainly inflammatory in its core. So you can imagine that it would also provoke other episodes of similar psychiatric decompensation as well. But yeah, nothing formal. I know that's kind of an unsatisfying answer, Cheryl, but more to come on that. Okay, Kristen Martin had to jump off and said thank you very much. I'll appreciate that, Kristen. Jody Stockhoff asks, I have an individual with moderate ID and is in her early 30s and is now showing signs of schizophrenia. Okay. The doctor says that it's very common for it to show up in the 30s. Is this the case, and is there a reason? Okay. Jody, I would say that stereotypically, people with schizophrenia present in their late teen years, early 20s. Women can present a little later. Early 30s would not be an atypical time for somebody with schizophrenia to present with schizophrenia. I would need to know a lot more about this person in particular to answer your question super accurately. All I'm going to say is that moderate ID, 30s, female, any kind of history of schizophrenia in the family, you know, it would lend more and more and more credence to this. So I would say that this can be the case, certainly, and unfortunately. Is there a reason for this to have developed the way it did? No. People with abnormal brains are, like we talked about earlier, a neurotypical person has like a 1% chance of developing schizophrenia, and it gets much higher if they have a family history of it. Folks who are neuroatypical, that triples, you know, doubles, triples that risk. And there's probably nothing that provoked these symptoms that your individual is experiencing. It just kind of goes that way sometimes. There's a stress diathesis model of the development of schizophrenia, which says that, hey, like very stressful events, either illness or just life experience, can increase people's chance of developing schizophrenia. I also want to put out that people can have episodes of psychosis, 1 or 2, and then never have them again. That also happens and doesn't necessarily mean somebody has schizophrenia per se. Schizophrenia itself is a diagnosis that has to be established over the course of several months with persistent symptoms. Talking like more than 6 months is a requirement. And if that's the case, then that diagnosis may be accurate for that individual. But good question, Jody. And in general, what our DSM says in a nice little box that works for a neurotypical patient may not apply perfectly in a person with intellectual disability. Those stereotypic symptoms may not be reflected one-to-one, and every individual patient needs to be taken in their own individual context when it comes to the length of symptoms, the severity of symptoms, and what contexts they either improve or remit in. Okay, I think, Megan, if you're in agreement, I think we might have wrapped it up with that last question from Ms. Stockhoff there. I just want to thank everybody for joining me today. Here's a list of my references you'll find on the back slide here. I just want to appreciate everyone who came for your dedication to this population and to your furthering your education. It's always refreshing to meet fellow enthusiasts when it comes to helping our intellectually disabled friends and family members, and it's something I'm really passionate about. I just want to say thank you again to OMHAS and the Department of Wright State Psychiatry and Dr. Julie Gentili for providing me this opportunity to spend time with all of you. Please feel free to email me and with any questions or concerns. And everyone, take care out there. Be safe. Thank you.